Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8-Minute Rule. I got Mark here with me today. Again, we're just trying to get you some quick hitter information and get some good quality within an 8 minutes. So I'm going to go ahead and lay a case out to us. We got a 42-year-old CrossFitter, 6 months of shoulder pain. MRI shows a partial thickness supraspinatus tear. That's pretty much all we're going to give there. So I'm going to go ahead and start up our timer here. We're going to get rolling with 8 minutes. Mark, how much do you weigh imaging initially here?
Honestly, not a lot, especially because what we know about imaging findings in asymptomatic individuals, it's likely that partial supraspinatus tear has been there for who knows how long and is a regular part of aging. What I am going to look at more is the clinical findings and find deficits and treat those deficits. I may not be doing a ton of special tests because those are also not great for the shoulder, but finding what the patient's having trouble with both functionally and then breaking down that functional movement into its pieces and then tackling those pieces to get them back to what they want to be able to do.
Yeah, I think that's really good. I will say just kind of a different thought process around it too. Obviously, this patient has already had imaging, and since that is the case, and we'll see that a lot of times when patients come in and they've had the MRI before we even get to see them, actually more of an opportunity there. All right, partial thickness supraspinatus tear. So they're here in our office, so obviously we're looking at non-op, so it's kind of a good opportunity to bring out the thought process, like, hey, this is what your MRI says. What are your thoughts there initially? Get some feedback. Either they're going to be on one side of the coin or the other, which is, oh gosh, I've got a tear. I was so fearful that was it. Hey, I've got a tear, but doctor said it was one that he doesn't think is surgical. You at least get to get those thoughts out and go ahead and have the conversation around, hey, great news that evidence shows a lot of people have these. Really good chance that you should be able to get back to doing the things that you want to do. So, yeah, I'm with you. Like I'm not going to weigh it, but since they've had the imaging, we can kind of use that as a little tool to get the light bulb moment going off there. As a whole, Mark, are you treating the shoulder or are you looking to treat the system here?
I think it's got to be a little bit of both to an extent. I mean, obviously, you need to address specific impairments in the shoulder, but at the same time, especially a CrossFitter, at no point are they really using their shoulder in isolation of other things. So, I mean, if you're talking about a kipping pull-up, I mean, there's a whole body system going on with that they need to be able to coordinate their shoulder with their thoracic spine, even their lumbar spine, and all the way up the chain as well. So yes, and it's a and not or situation. Yeah, I may need to target some very specific isolated shoulder movements, but then you've got to put it all together into your snatch, your position, your power clean and press position, all of those things to help this person get back to what they need to be able to do.
Yeah, I mean, obviously it's a very vague case, but the goal of that is that it can vary to a broader stance as opposed to just this individual that we're talking about. And to your point, anytime I've seen a supraspinatus tear, we probably know it didn't come on with whatever incident that they first started feeling the pain, right? It's probably something that's been there. And so, to your point, I need them to be able to do kipping pull-ups. I need them to be able to do handstand push. That's not just hey, I'm going to work on external rotation, open chain, right? I need them to be able to do a lot of different things. So evaluating what the closed chain system looks like, evaluating different positions that, obviously a CrossFitter is going to need to work through as well is going to give you the most value there as opposed to just specifically in isolation. So I think as a whole, we're trying to treat that much more so than just one specific area as well. Taking that out a step further, what are your flags for referral? This could be red flags. This could just be flags that, hey, this person actually needs more than just typical musculoskeletal PT rehab.
Yeah, so first thing obviously is any red flags. Is it something more ominous? Is it a Pancoast tumor? We're talking about a CrossFitter, is it possible they have rhabdoin or having a lot of other symptoms? Like all of those things are on my radar, or cardiac or something, right? So assuming that I've ruled all of that down, which hopefully I have done that very quickly, something that will lead me down the lines of like, man, we need to at least have a conversation about a referral is like significant weakness, meaning I can't lift my arm against gravity. or significant muscle wasting. And that would look like, you can get into the groove of the scapula there and like there's just nothing there. Both of those things are on my radar because it could be that they've got actually a neurological deficit that's causing them this problem that they're having. In which case, like, I'm probably not the person that's going to be treating a like actual palsy at this point. I could treat the aftermath, or they've got such a significant, or maybe they have now such a significant tear that it's not functioning the way that it needs to. I know that what the MRI showed at one point. Now, fast forward to however long, maybe it is substantial to the point where they have such a tear that it's going to be hard to manage it conservatively. Now, that's where the conversation comes in. Can you manage it conservatively, a full rupture? Absolutely. But it's going to depend on what the patient's goals are. If they're a construction worker and need to be able to do a lot of heavy lifting and things, then they probably are going to need to have surgery to surgically repair that, because in my experience, yes, you can rehab it, but like the ceiling effect is much lower. Their outcome is going to be a little bit lower than what it could be potentially, or what it previously was.
Yeah, spot on. I think one of the things that I tend to look at, as you said, atrophy to me is an immediate sign that we need to make sure at least something's going on here further. This patient, they've had an MRI, likely coming from an orthopedic. Maybe not if they're coming from PCP versus ortho, may weigh in, as you said, if I have that atrophy there. The pain's always the tricky one, right? I've seen plenty of shoulder injuries. People had trouble lifting their arm. Literally, if it's, you got to get stuff calmed down and really get a good picture for it. Inability to lift your arm 3 weeks past the acute event is a big difference between, hey, this happened yesterday, 2 days ago. But I know, and I could be wrong on this, but I think one of the more recent tests around just drop arm test along with external rotation being painful actually has a pretty significant standard for being able to rule out some of the full thickness tears. So kind of an easy little quick screen on there. But I think as a whole, this is one of my soapboxes as well as PTs. If you've got a patient here that's been sent to you from an orthopedic with a partial thickness tear, and your red flag screening goes past, as you said, goes past the cardiac, goes past the neurological deficits, then you really have, you're playing with house money to some degree, right? So you're trying to get them in a place where we want to get you functional, having the conversations around, yeah, there could be some pain here early on, but obviously we want to get you back, one, calm it down, dial things back a little bit, get you stronger, get you moving better, and then we're going to start working you into those loads. So obviously introducing some of your positions, CrossFitter athletes, and many other athletes in general, right? They don't want to stop doing what they've done because that's what really drives them to doing a lot of things they do. So you got to kind of weigh those things together and how much you want to pull them back versus how much you want to push them forward. So good stuff. As always, Mark, we're going to stop it there. And until next episode.